Hello everyone, I'm Anne Cumming and I'm the Principal Advisor for Cognitive Impairment at the Australian Commission on Safety and Quality in Healthcare. And thank you for inviting me to present at your conference today. Thank you, Gideon, for launching the updated 2021 Delirium Clinical Care Standard yesterday. It's 5 years since you helped us launch the original back at the Delirium conference in 2016, and it's great that the updated version has been launched here at this conference. So today I'm going to give you a little bit of a background to the development of the standard. What is a clinical care standard? How does it relate to the National Safety Quality Health Service standards? And what changes have been made in the updated version? And lastly, what is your role? And then I'll hand over to Sue Curl to reflect on what differences it has made. So back in 2013, when the Commission was consulting on the development of the better way to care for cognitive impairment, we received a lot of feedback from clinicians in consultation that we need to better clinically manage, recognise and prevent delirium. The Commission took that message on board. It did its homework, further consideration, and included the Delirium Clinical Care Standard in its Clinical Care Standard program work. And it was for all the reasons that the audience today would be aware of, that delirium is a common condition, can have serious consequences, it can be a terrifying experience, and at the time it was quite under-recognised, and that has high costs associated with it. So the Delirium Clinical Care Standard was developed and released in 2016. So a clinical care standard is a small number of concise recommendation or quality statements about the management of a particular clinical condition. It does not replace clinical practice guidelines, but focuses on high priority areas of quality improvement. A good clinical care standard is accompanied by a set of indicators to allow monitoring, and it has information for the three key audiences, and that's the consumer, the clinician, and the health service. As with all clinical care standards, the Delirium Clinical Care Standard was endorsed by relevant clinical colleges, professional societies, and consumer groups. So back to the consultation I mentioned earlier, another important message was if cognitive impairment, including delirium, wasn't in the National Safety and Health Service standards, it wouldn't get the attention it deserved. The timing was really good because the Commission was reviewing the first edition of the standards. So after consultation and revisions and a lot of debate, cognitive impairment and the Delirium Clinical Care Standard was included under the new standard in the second edition, and that was comprehensive care. For those of you who are not aware, the National Safety and Quality Health Service standards are mandatory for all public-private hospitals, day surgeries and public dental practices, and they focus on the systems and processes to support clinicians to provide safe and high-quality care. Their development has been a collaborative effort with all government, states and territories, clinical experts and consumers. And the second version was released in 2017, and assessment to them started in January 2019. The clinical care standards are linked to the National Safety and Quality Health Service standards in a number of ways. So under clinical governance, which is the first standard and an overarching standard, under Action 1.27, health service organisations are required to have processes to support clinicians to use the best available evidence, including relevant clinical care standards. There are specific cognitive impairment actions in the National Safety and Quality Health Service Standard, Action 5.29, includes the health service organisation has a system for caring for patients with cognitive impairment that incorporate best practice strategies, including the Delirium Clinical Care Standard. So that's another place where it is specifically mentioned. Another area where it's mentioned is under the last standard, which is around recognising and responding to acute deterioration. And under Action 8.5, health service organisations are required to have processes in place to monitor patients at risk of acute deterioration, including patients at risk of developing delirium. And when there are changes in a person's behaviour or cognition or perception, etc., they are assessed for possible causes, and that, again, that includes delirium. So from 2016 to 19, we ran the Caring for Cognitive Impairment campaign to help prepare hospitals and clinicians for the new items under the National Safety and Quality Health Service Standards. And as I said, assessment to these standards took place from January 2019. And for that campaign, we had over 2,000 wonderful champions, and thank you from Anne-Marie Hosey and Karen Harvey here for their leadership in that process. So for the review of the Delirium Clinical Care Standard, there was a review of what had happened in terms of current delirium guidelines and the evidence, and the original endorsing organisations were informed of the review, and our original topic working group was reconvened, and there was a targeted consultation process, and our standing committees, which consist of our interjurisdictional committee and our primary care and private sector committees, were also consulted. So it was then updated and revised, and then endorsement was sought again from the key organisations. So what's changed? So the main changes have been firstly adding Quality Statement 3, which is around patient-centred information and support. Statement 6, preventing complications of care, is an expansion on the original one. And Quality Statement 7 around antipsychotic use has been updated and strengthened. The first statement, there's been just a minor change from the title, from early screening to early identification of risk. And here, a patient with any risk factor for delirium is identified on presentation, and a validated tool is used to screen for cognitive impairment. And before any planned admission, the risk of delirium is assessed and discussed with the patient to enable an informed decision about the benefits and risks. So Statement 2 in the original standard was assessing delirium. So the order was changed to more logically follow the patient pathway of care, so that you try and prevent it first, and then you involve the family, the person, and then you assess it when you suspect that somebody may have developed delirium. So interventions to prevent delirium, I'm sure the audience is aware of those, such as reviewing medicines, keeping a person hydrated, nourished, mobile, orientated, and awake at the right times, and having family and someone familiar with the person. As mentioned before, this is a new quality statement. The importance of information and involvement of family was in the last version, but it's been made a quality statement to make it more explicit and provide more emphasis on this important area. So in this quality statement, a patient at risk of delirium and their family or carer are encouraged to be active participants in care. If a patient is at significant risk or has delirium, they and their family are provided with information about delirium and its prevention in a way that they can understand. When delirium occurs, they can receive support to cope with the experience and its effects. So in the first statement, you have screened for cognitive impairment, and so if they have cognitive impairment or there's an acute change in behaviour or cognitive function during a hospital stay, the person is promptly assessed for delirium. Now, the Commission doesn't mandate any particular tool, validated tool, because there are already tools embedded in hospital systems. But I'll just mention here that the 4AT has become a popular tool with reports that it is quick and easy to use, and it does have the advantage of having inbuilt cognitive scores that meet the cognitive screening requirement of the statement in quality, the quality statement number 1. So identifying and treating underlying causes remains the same. Of course, the process doesn't stop at diagnosing. You need to try and work out what is causing the delirium and hopefully treating the underlying cause. And as mentioned previously, number 6, preventing complication of care is an expansion. Previously, it only referred to falls and pressure injuries as it aligned to the 2 standards in the first edition of the National Safety and Quality Health Service Standards. But now it's been expanded to include preventing the range of complications of care, such as functional decline, dehydration, malnutrition, falls and pressure injuries. The Queensland Eat, Walk, Engage program that has been presented at this conference, I think, is a really excellent example of how you might implement this. So number 7 used to say minimising the use of antipsychotics, and so it's been strengthened to say avoiding use. It reflects current evidence that antipsychotic medicines are not recommended to treat delirium, and when there are behavioural and psychological symptoms in a person with delirium, these are managed using non-drug strategies if at all possible. Last but not least is, of course, the transition from hospital care. So here, an individualised comprehensive care plan is developed collaboratively with the person and their family or carer, and it describes a patient's post-discharge care needs and includes strategies to help reduce the risk of delirium. And it summarises any changes in medicines and any other ongoing treatment. And this plan is provided to the person and their family or carer before discharge and to the GP and other regular clinicians within 48 hours of discharge. Each of the quality statements have indicators that enable care to be monitored and to support quality improvement. The Delirium Clinical Care Standard is part of the National Safety and Quality Health Service Standards, as we described earlier. Therefore, organisations can provide evidence of compliance with actions related to delirium by using the indicators in the Clinical Care Standard. So do go to our website and download the additional resources that accompany the updated Delirium Clinical Care Standard. So there are some wonderful examples of clinicians and managers coming together to improve the prevention, recognition and management of delirium. And this has made a positive difference to the experience of patients across Australia. So thank you to those who are already familiar with the Delirium Clinical Care Standard and started on their quality improvement journey. And those I would imagine a lot of people have also been inspired by the many examples at this conference. So I'm now going to hand over to Professor Sue Curl, who is our chair of our Cognitive Impairment Advisory Group and is also the star of many of our educational videos. In Sue's clinical role, she has witnessed many improvements in delirium care and will share some of these with us today. So thank you very much.